I'd like to turn it over to Nicole Clement, our program specialist, to kick off today's event. Nicole, thank you for joining us, and I will now turn it over to you.
Thanks, Kiona. Welcome, everybody. I'm glad to see we have such a good turnout. I think this topic is obviously timely. You can't talk about anything COVID and not be talking about the right thing at the right time, right? It kind of seems to be the never-ending issue right now. So thank you to our speakers who agreed to participate. We have Andy Gienap of the Wyoming Office of EMS, and we have Steve McCoy of the Florida Office of EMS, one state that has been hit really hard and one state that has been hit less hard, but that doesn't make it not an issue still. So that's why I picked those two speakers. I thought they would both have a lot to share with us in that regard. And then we also have Aaron Reinert of the American Ambulance Association and also the director of Lakes Region EMS, so an ambulance service here in Minnesota. The three of them are going to share with us their experience with COVID so far. Andy, if you have anything else you want to add in introduction of yourself, that would be great. Otherwise, you can go ahead and get started. And Steve, when it's your turn, same. If you have any background that you want to provide, that would be great. Fiona, do they know how to share their screens? If not, do you want to help them do that?
We're going to kick it off with Andy. So you are welcome to press the share the screen button, which is on the ribbon that will appear on your lower half of your screen.
Okay. Well, thank you. And so while I'm talking, let me bring up the slides because I was not anticipating that. Sorry. And let's see here. Share screen. This is the one that I want. And you should be able to see it now. Nicole, can you confirm that?
Yep, I see it.
Okay. Well, thanks for having me. It was fun to look at the list of participants and see a lot of my colleagues and some faces that I have not seen in some time because of COVID. So certainly to all of you, my best wishes. I hope one day we'll be able to be in the same place again. I am the state EMS director for the Wyoming Office of EMS, which houses all of the EMS functions for the state, as well as the statewide trauma program and the hospital preparedness program, which is, of course, the ASPR funded grant. So that's really high level of what my office does. I am the current president-elect for the National Association of State EMS Officials, which is the capacity in which many of you may know me. And I co-chair the Joint Committee on Rural Emergency Care with my colleague Joyce Hospiter with the Arizona Office of Rural Health. That committee is a joint effort of several organizations to make that happen. It's focused on all things rural emergency care. So then, my slides are not going to take very long. Wyoming, if you have not been paying much attention to Wyoming, which is understandable since many of you live in states that got hit far worse with COVID than we did, we have not seen the total, the proportionate number of cases even to our population. Roughly our population statewide is about 560,000, somewhere in there, give or take any boom or bust in the coal and oil industry. But so we have a very, we're very low population. So we haven't even seen the proportionate level. And this slide that you're looking at right now is even maybe 3 or 4 days old, but still statewide total number of COVID cases that we've seen is still under 1,300 with only 20 reported deaths. So it has, I don't want to say it has not been a big deal, because it absolutely has been a big deal managing this problem in Wyoming. We just have not had to deal with what you're getting ready to see from Steve McCoy, for example, as to what Florida or the Texas experience is. But at any rate, this is our case total running as you see there. And so we'll just get right into what we did. So the first thing was, So the first thing that became apparent in rural Wyoming was the limited testing capacity. Part of that was due to the need for the CDC to verify and validate sites to be able to do the testing. We only have one state lab in the state, and that was our only point of testing. Of course, now we've gotten private lab on board. So that was a problem for Wyoming early on, just the demand for testing. Everybody wanted that, and we had very little capacity to do that. The next big thing as it relates to EMS was that because we're a state agency, just like I'm sure Steve is going to tell you, I and all of my staff got immediately pulled into managing the event from the state level, working the EOC on various things, hospital reporting and helping get some data in, developing transportation plans, and kind of managing those things that we're particularly familiar with that the State Department of Health was not as familiar with. So when me and my staff, when we became engaged in the work at the EOC, that basically meant that everything else ground to a halt to a large extent. And all of my folks, a very small staff, there's only 8 of us right now, all of us were engaged at some level and participating in some way to support the overall state effort. Certainly happy to provide more detail about that as we went along, but basically it was all hands on deck. And I'll tell you, the other thing too was that by virtue of the HPP program being housed within the Office of EMS, we were the only ones who had any capability or system in place to be able to report on bed status and ventilator status, those things that became really paramount that everybody wanted to know in the management of the event. Things that we observed immediately as it relates to EMS agencies out in the state. Of course, an immediate demand became for thermometers, which I found a little surprising because I thought, this is 2020. How can it possibly be that there are ambulances out there that do not have thermometers? But that was absolutely the case. And so we had to quick backfill to try to get that solved. PPE, the ambulance services did not have an adequate stockpile in place. Some did have access to like PAPRs and CAPRs, but not everyone did. And of course, those are expensive items to kind of keep on the shelf. We've seen a lot of confusion as related to the medical director versus maybe a county health officer or the state health officer versus physicians or whomever a medical authority would be in the hospital. That created a lot of confusion, some of which still exists today. Now, there are a couple of instances in our counties in Wyoming where the EMS medical director is also the county health officer, who is also the physician working in the local ED. So in those situations, it's pretty easy to figure out where you're taking your direction from. But having to deconflict quickly between, well, are we transporting a patient or are we not transporting a patient, and which problem trumps which one, having to work through that. We early on had I'm not quite sure the politically correct way of putting this, but had some instances of EMS crews and fire crews not taking the risk of exposure seriously. And we're talking about a point in time where we knew we had active cases going on and that there were responses that were happening, and we had done everything that we thought we could do from the state health officer and out of my office and other programs saying, hey, this is real, it's going on, you need to protect yourselves, you need to protect your crew members. And we still had crew members who were going in to treat patients who were not protecting themselves appropriately with PPE. That one was kind of easy to react to because it prompted an email from me that basically said in a firm and yet kind way, you guys need to get with the program. So other things that we did, we were pushing guidance as fast as we could, coming from both from the state and from the CDC, World Health Organization. We did try to make sure that whatever we were distributing was in alignment with whatever our state health officer was saying. So that was a big activity for us. We removed, we were fortunate that we had done some hard work on the front end as it relates to getting Wyoming to be a compact state, and also some other work within our own administrative rules to address licensing gaps. We had done that years ago. So by the time we got to the point where we may need to license a lot of people really fast, we had a lot of mechanisms in place where we could do that. And of course, I was involved with the Replica Commission in that. We had existing Medicaid rules that provided reimbursement for a treat and release or treat at home for our community paramedic programs. So again, by virtue of being a small state, it was pretty easy for me to work directly with the Medicaid office and say, hey, for our Medicaid patients for EMS agencies that take care of a Medicaid recipient or Medicaid client, we need to make these broader, and they were happy to do that. We were able to get that done very quickly. EM Resources, the electronic system that I mentioned before, that's paid for through the ASPR grant and managed by the Hospital Preparedness Program. We were typically, EMS agencies don't report in there, and they certainly don't typically report their PPE in there, but we expanded the capability of that program and used that system in order to get the reporting in on PPE status and patient status for hospitals and EMS. And then the big thing that we did, many of our agencies already had the IM Responding app, but we were able to set up a statewide account here within our office so that we could reach out and we could ping any of our ambulance services if we need, in the event that we needed them. We have not used that to date, but it is in place in the event that we need to do that. So this is just my perspective, and I certainly own all opinions that are in here. But
Andy,
here's what I think we need to fix before we get to the pandemic round 2, or now that we're in pandemic round 2. Lack of leadership at the local level. And I use the thermometers as an example. There's no reason in the world why a modern day ambulance in 2020 doesn't already have a thermometer. And I put the buck stops here, so I take some responsibility for that. But we need to be sure that our leaders understand what modern care is and that they're able to provide it. Minimal staffing. When you have ambulance services who have a crew of 3, 4, or 5, and they transport a COVID patient, either knowingly or unknowingly, and then you have to quarantine that crew, that can put a real hamper in your services. And that absolutely has happened in some of our Wyoming towns where they've lost access to crew members for 7 to 14 days while they quarantined. The funding issue, and I'm sure that Aaron and Steve are going to also hit on this, or other folks, that we created a damned if you do, damned if you don't situation for EMS, in that the way that we fund and we pay for EMS stood in direct opposition to what we were actually asking them to do to manage the event. And the thing that is frustrating about that is that there's no reason for it to be like that. We can do better as it relates to how we conceptualize and pay for EMS, and it's time to do that. And I think the pandemic has just shown that. Not being integrated at the local level, you're dealing with multiple agencies, you're dealing with local public health, you're dealing with the local county emergency management, you've got EMS involved there. Having all of those people be aware of what EMS and what EMS is capable of, and having EMS understand who those parties are and how that response is happening in their county means that we can get used as a resource better, and that we can be involved with the planning. Disengaged medical directors, which it's tough in a rural community when your medical director is also the ED person and the county health officer and in charge of the OSHA compliance and probably in charge of the house cleaning staff and 100 other things that distract from them, that makes it hard for them to give the kind of clinical attention to EMS that EMS probably needs. So as we get into that next one, here's where I think we need to have, or what we need to have. We have to have a better emphasis on planning and preparedness for EMS. You know, we talk a lot about not counting Band-Aids, meaning we don't want to get into the weeds and go back to the old days of you must have this many Band-Aids on your ambulance. But maybe we do in some ways. I mean, how do we make sure that ambulances have things like thermometers and PPE and cappers and PAPRs and those things that are important? I think regionalizing medical direction, finding ways to do that, to get those folks who have those physicians who have clinical expertise in EMS involved. Adding bandwidth and telehealth connections, another difficult problem in rural America, especially in Wyoming. Getting EMS to view themselves as part of a bigger response picture rather than just answering the 911 call. You call, we haul, that's all. And then calling on CMS to lead the change as it relates to how we pay for funding. It doesn't all lie at the feet of CMS, but CMS stands at the perfect position to be able to help lead a different way to do this. So that's it. I'm sure my email address will be up there later, but I will end this and stop sharing my screen.
Andy, before we let the participants ask any questions, I just was wondering if you could give a super brief overview of what Replica is. Not every Flex program is even opted into EMS activities, so some of them don't have that deeper knowledge.
Yeah, sure. Replica stands for Recognition of EMS Personnel Licensure Interstate Compact. So many of you may be familiar with the term compact, having heard legislation in your states related to the nursing compact or the physician compact. So basically it is model legislation that can be adopted by a state, which then allows the state to develop means and work with the other states who are also signatories to that compact to be able to find ways to allow EMS personnel to cross borders easily without the need to maintain multiple licenses. That's the way I can put it most succinctly. There are now 18, I believe it's 18, maybe 19 states that are signers to that compact.
Great, thanks, Andy. Anybody have questions for Andy before we move on and have Steve talk about what's going on in Florida? All right, thanks, Andy. I have some questions for you at the end, so I'll come back to you. Yeah. Steve McCoy in Florida, if you could unmute your line and share your slides. If sharing your slides is an issue at all, we could do that for you.
Can you hear me?
Yep, I hear you and I see your slides.
All right. Well, thank you, and I will not talk nearly as long as Andy. He's got the gift of gab. So real quick, a little bit about me in Florida and what we got going on, and the volumes are different, but some of the same issues we have here, no matter how big or small you are. But you know, I'm Steve McCoy. I'm the state EMS director for the state of Florida, and how we're set up in Florida is we have the Department of Health, we have the Division of Emergency Management, and we have the Agency for Healthcare Administration. Those are kind of the three primary entities that are responding to COVID and working together to kind of get that response in several different ways. It might be in response to long-term care, response to medical surge issues, and so forth. So my primary job is I'm responsible for the Department of Health's response to long-term care facilities, our nursing homes, assisted living facilities, intermediate care facilities, and things like that. So not that I volunteered, but somehow I got shanghaied into the response to our nursing homes and so forth back in February now. So it's been well over 100 some days that we've been going at it. So so far, in Florida, we're up to 213,000 cases. I think we have over 16,000 hospitalizations, and unfortunately, we're over 3,800 deaths in the state of Florida. So primarily, our deaths have been long-term care. 40–50% of that long-term care, and that's just rough guesstimates on the numbers, but those are our most vulnerable citizens, and those are the ones that we've really been trying to put a focus on and taking care of. And EMS has been a big component of that from the beginning. We just like Andy said, we've seen a lot of things and some changes that have brought forward in our state from COVID, and what we've been forced to look at, and what some of the trials and tribulations that we've been faced with. PPE shortages. Andy mentioned that one, so I'm not going to go a lot. And it was basically the same types of shortage. And then one of our big questions is when we have a disaster, we're looking at what's the emergency management and Department of Health and Agency for Healthcare Administration have to come together, especially when you have such a strained resource. You got to kind of figure out how to distribute that. And there was a lot of confusion back and forth between, funding, distribution for public versus private. And in Florida and like many other states, all things are local. And disasters are local for us, and so we've got our cash in from HHS and other sources, and we push that down to the county level and have the county EMS work on the distribution methodology for their county. Not all counties and have that relationship with their EMS service from the EM perspective. And then also, with our laser beam focus that we have on long-term care facilities, we have to, we want to make sure that they're getting that. So we had to really earmark for some for public safety, and then also some for our long-term care facilities at the same time. And it's just a balance that we have to play at the state level of who's going to get what when we have such a strained resources. So a lot of that was just pushed down to the county level for the counties to make that decision. We try to push everything on that local side. So PPE definitely was an issue. Initially, there was issues around the guidance of PPE. The CDC did a great job and has continued to do a great job of putting out guidance. But some of that was, there were some areas that were left for interpretation. And, we were asked to make that interpretation. And we didn't always do that. We kind of allowed them to make that decision on different types of PPE usage. So once again, everything's local. Changes in disaster preparedness and response. I think last month we had our first tropical storm. And those of you might know it, we get storms pretty regularly, hurricanes and things like this. And we're pretty used to hurricanes. And it's nothing for us to evacuate a coastline and move from the East Coast to the West Coast, and all the healthcare facilities in a given area to move that whole population. And we've done it in the past. Now it's different. The term non-congregate sheltering has come up because we know that our standard transportation and evacuation procedures are not going to be the same anymore. It will never be the same. I don't think we'll go back to the way things were before, because now we have to take into account a healthcare facility's COVID positive count? Where are they going to go? Is there appropriate isolation procedures for them there? And how are we going to get them there? Do we, a lot of times we use paratransit vehicles in some of our ambulatory patients, and we work with paratransit companies. And so we ran into this earlier when we were moving some patients that were coming back to Florida from overseas. And we were working with paratransit companies like we normally do, but then now we come into play with unions. The unions of these paratransit companies felt that we were putting their members in danger. So there was a lot of discussions that I had to have with unions and things like this, and assure them that we were taking care of them. And when we first started this in March and April, there were so many questions about it. They weren't really sure what we were dealing with 100%. So, it was a lot of working with that. And we had, some other discrepancies with some other larger unions in the state based on our interpretation of CDC's guidelines versus their interpretation. So there's a lot of that had to be dealt with to get these patients where we are. But, there's a lot of changes in disaster preparedness. It's not going to be the same anymore. So we're having to take that into play. Longer transports, we're going to see these because it used to, our facilities have their agreements in place for their transport facilities, but now that's not the case in every single thing with COVID positive patients. We've urged our healthcare facilities and our EMS agencies to work with them to talk about where are they going to put these patients, because we know that their plans, their kind of county or local emergency management plans aren't going to be the same. Have they updated those plans? And that's the one thing that makes Florida different in some of the other things is the resiliency. Our healthcare providers, our EMS services, they are, they're battle tested in a lot of different areas. So they have these plans in place. They practice these. They know what they're supposed to do most of the time. So we try to make sure that these plans are updated and they're accounting for this new disease process that we have to incorporate in as well. Another discrepancy that we had to kind of settle from a state level was access into the long-term care facilities for screening. A lot of our services felt that they didn't need to go through the long-term care facility screening process. They didn't need to have their temperature taken. They had it taken that morning when they got to work. No, not necessarily. We make our EMS services submit to an agency screening process if asked. And then the question comes in, well, what if it's an emergency? Well, that's on that facility. You've been called there to their emergency, so and they control the access to that facility. So if they require you to go through that screening, we ask them that they submit to that actual screening. And our facilities have been on lockdown for months now, so we know that if we have COVID in a long-term care facility, it came from somebody else that was on the outside, and we don't want that to be coming from EMS. So we definitely require them to submit to the screening and wear PPE as they go in there. The next couple slides, we're going to talk about some decrease in staffing and some of the lower call volumes. The slide here is basically some of the call volumes, and this is by week over the past, 6 months. But you can see prior to this, we're running 80, 90,000 calls a week. And then here in March is when our state stopped elective surgeries. We went on a lot of mandatory quarantine type things and some curfews and things like that. And we've seen record low call volumes that we've never seen before in the state. And what that did is, and for our larger public, fire service agencies, that it wasn't a big hit, but to some of our EMS companies, it's a big hit. because that's their bread and butter, and that's how they make money. I mean, honestly, and to be honest with you, it's the private companies that we work with in disaster situations to do these transfers and everything else. So me as a state, I can't afford for companies to go out of business. I need these companies to do those transfers that I spoke of earlier. When you evacuate one coastline to the next, you got to have more than just one or two ambulances from this fire service and one from this third service. We need massive amounts of units to make this happen and make it happen successfully. So this little dip here really hurt in some of our services. So we do what we can as a state to support them, and I'll talk a little bit about that here in a minute. And then we had some reopening. Elective surgeries came back, so you see the increase coming back up. So here is a survey from our professional firefighters. You'll see here and this is the impact of COVID on the actual staffing itself. Ordinarily, when we're looking at less than 5%, we've seen that creep up in the past 2 to 3 weeks. We've seen this creep up. We were very fortunate in the beginning of this. Our governor locked things down quickly, and we didn't see the bump that we've seen in other places. Now we're starting to see that. We're starting to see some increase in cases. So in those increasing cases, we're seeing it in our actual staff themselves. Myself and our state medical director, Dr. Kenneth Shepke, have been on state calls, and it's not only when you're on a call that you need to appropriate social distance and you need to wear your mask. But at the fire stations, at the EMS stations, that's in play too. So you have to practice what you preach when you're at the EMS station themselves. That's where it's coming from, and that's hurting. They're not getting this disease on calls. They're getting it back at the station, and from family members or wherever else in the community. So it's not only when you're on duty. It's when you're off duty, and we're trying to continue to preach that appropriate social distancing and wearing of face coverings and things like that. So really, we want to push face coverings in some areas, but it is a right for those to do it. So, but we do notice the value of that. Here is some of the repurpose of resources, and this is when I talked about what did we do when we seen that our ambulance services were hurting, our private services. We have state missions, and one of the first things that we did is I contracted as a state with several agencies to actually do long-term care facility assessments. The contract rate for us is $190 an hour for ALS and $160 an hour for BLS. And we contract with them to actually do an assessment of every single long-term care facility in the state, so well over 4,000 of those. And they go there and they did the assessments of those. Mobile testing teams, same thing. There's a lot of people that can't make it out to a drive-through testing site or a mobile testing site that's put on by the county or by public-private entities. They can't make it out. So these may be special needs type clients and patients that we see that just don't have the ability to go out and do that. Well, we've created ambulance strike teams, and we've done whole neighborhoods in testing and so forth. I've used paramedics and EMTs in staffing these major drive-throughs. We have drive-throughs, and they're doing antibody testing. They were doing antibody testing back when it was only a venous type thing through Celex testing. So yeah, I mean, we use them in every way that we can. And then state-sponsored interfacility transports. We have this graphic here is of our state COVID receiving facilities. We can't put COVID positive patients back into our long-term care facilities. They have to go to a regional receiving facility. So when they're discharged from the hospital, or if we have a long-term care facility that can't appropriately isolate those patients, we don't allow them to stay there. They have to move out, and they have to go to these regional receiving facilities. They have to go into the healthcare system, or they have to go to another facility. And a lot of times the state, I create missions to evacuate those facilities. I've evacuated several facilities because they couldn't isolate patients correctly. So we moved those patients. And this is where I've repurposed those resources to work for the state. And it's been great for some of the private entities. So, but all in all, I mean, that's, I don't think we're going back to what we've seen before. This has changed us permanently. It's definitely changed my office. I mean, we're probably 85%, COVID right now, and we will continue to do that. So, but really, we'll press on and we'll keep going. We're seeing an increase in our cases now. We probably will see an increase for a little while, but we'll do what we can to push on and get through it. So, Nicole, does it for me. I'll turn it back over to you. You got it, Nicole? I think you're muted.
Thank you. There was a question in the chat for you from John I. Let's bring that up really quick. John was asking about data sharing. He said, with the lack of data being published on the Florida Department of Health website, how are both the county and local emergency managers and state level folks assessing their caseloads, risk, etc.? And now you're muted. There we go.
Okay, I think I got it now. Well, I mean, as far as data sharing, we've done what we can with the county health officers, and we've shared all of that, the case volume that we have. We did run into some issues with sharing results with employers of a lot of times the EMS agency's employer wanted to receive test results. And that was, our general counsel felt that was a violation of HIPAA and said no. And then we also initially we had feeds going through our state public safety answering points. They would push the list of positive patients out to each PSAP. So they can populate their PSAP to say where the positive patients were. And that way, when our EMS services were responding to these areas, they could know if they were responding to a positive patient or not. However, that process stopped last week. And what we were doing, we found out that it gave a false presentation that you were responding to a place that did not have COVID. So now we treat every house as this is a COVID positive house, and that's for the safety of our medics and EMTs.
Mm-hmm. Great. Another question for you: the slide that you shared about repurposed resources. So talking about what ambulance service staff are doing. You're talking about ambulance service staff, right? Not your staff in your office of EMS?
Right.
Okay.
And that is, EMTs and paramedics that work for services. And then that's to keep those services afloat. We want to help our services out. This is a resource, a force multiplier that people have to tap into, especially in these other states. These are a lot of resources that they're not running a lot of call volume now. So I urge other states to tap into that EMS resource.
Yeah. So those activities are helping to sustain them financially. Is there some payment in that for them?
Oh yes, without a doubt. I mean, we contract with them, and I mean, I'm very upfront. We contract with them at $190 an hour for an ALS unit and $160 an hour for a BLS unit, and it's a win-win. They help us, we help them.
Okay, thanks.
And I see that. I think John's got one more question, and then this is a lot of that data is on our publicly shared COVID-19 dashboard. All the number of cases, positives, negatives, ICU beds, all that's published either between our COVID-19 dashboard or in our Agency for Healthcare Administration's dashboard that they have. All of that data is very publicly available.
So then I have a question for Steve and Andy both. And then if anybody else has questions, any of the participants, feel free to unmute your lines, ask your question, ask it in the chat, turn your webcam on and ask it. I will tell you, if you turn your webcam on, you'll be part of the recording that is going to be publicly posted on our website. So consider that. But I do encourage you to unmute your line and ask your question if you have it. So my question for Steve and Andy is, and I feel like, you know, Steve for sure is so heavily involved with the Flex program in Florida. This will be easy enough, I think, for you to answer. Andy, I know you've been involved with your Flex program in Wyoming too, and Kyle has a relationship with you. So with that said, what could Flex programs do to support state offices of EMS and the rural ambulance services during this public health emergency?
Well, and Andy, I'll go first because I know you're going to talk for a long time. I mean, I think one of the things that we've seen is the expansion of telehealth and community paramedicine, which has been some of the focus of those programs for a while. But it's going to have to be ramped up another level. I mean, telehealth, a lot of our laws have went away in some of this aspect, so we can actually do telehealth and keep patients out that don't need to go to the hospital. There's just no sense in it anymore. And I think that people finally opened their eyes to it. So whatever we can do to support those rural agencies, I think we got a project we're working on here in Florida to support that with our critical access hospitals is definitely something that's going to be needed.
Thanks.
When this is over, Nicole, I want you to go back and look at the timestamps because I'm pretty sure Steve talked as long as I did. And I want an exact record of this. No, but my partner down there in Florida is dead on. It was absolutely going to be one of the first things. Emphasis on telehealth would be right at the top. That's a very difficult, seven-headed hydra to get hold of out here in Wyoming when there's only so much that anybody with telehealth can do out here until we have the infrastructure. But emphasizing that is a big one. Other things that Flex has paid for or helped provide assistance with in the past that are big in there, certainly the community paramedic efforts, because I'm right on board with Steve. We're not going back. So supporting that, the leadership training and efforts that is supported, that's been a big one. And then I would say that for those of you that are running these Flex programs in your state, the Flex is a CMS program, and get anything that you can do to advocate on behalf of helping get the funding model changed. And the reason that is so important is that if CMS will make the change, the private insurers and the rest of the world will go along with it. And that's why I say they're at the perfect position to help lead some change. But that's just my thoughts on that.
Sure. So Flex programs can't spend their money to advocate. State offices of rural health do Hill visits and such. So outside of the Federal Office of Rural Health Policy Funds, your message is absolutely well received about advocating for EMS and that sort of thing. And I think you were speaking Aaron Reinert's language when you started talking about that. So I'm going to actually turn it over to Aaron and have him talk about resources and such that are available, and if he has any thoughts he wants to add to this conversation.
Thanks, Nicole, and good afternoon, everybody. As Nicole mentioned, my name is Aaron Reinert. My day job is the Executive Director and Chief of EMS for an ambulance service, community ambulance service that serves rural parts of Minnesota and Wisconsin. I'm also honored to serve as the president for the American Ambulance Association. The AAA represents 75 plus % of the 911 calls that happen across the United States. Often it's assumed that the AAA only represents large for-profit members, but actually our largest membership group are small, not-for-profit, hospital-based, governmental ambulances spread all across the United States. So I wanted to share a little bit about what's happening federally and really mirrors so much of the great information shared by Andy and by Steve. So wanted to just talk a little bit about the national perspective for COVID-19. I think we've always known, and especially the FLEX programs that work with emergency medical services, especially rural, remote, and frontier, how fragile those EMS services were and continue to be. And often we perceive that fragility was around workforce, finding and keeping volunteers. Really underneath of that always was the fragility of the system from a financial standpoint as well. COVID-19 hasn't made them more fragile. I think it has simply shined the light, held the mirror up to how fragile the EMS system was. When we brought a number of these factors to these systems, many of them have begun to fail, some of them have already failed. And really we'll talk a little bit more about them and about that. As I mentioned, it's really shined the lights on the resources available or not available to ambulance services based on their ownership type. So all across America, it feels like at the federal level, it's assumed that ambulance services are fire-based. And so many of the federal programs that are available for the costs of readiness, for the reimbursement of costs after disasters, hurricanes, like Steve was talking about, such as reimbursement through FEMA, is tied almost exclusively to governmental ambulance services. And I really appreciated Steve talking about how his state and many others often rely on non-governmental ambulance services, whether those are not-for-profits, hospital-based, private for-profits. Often the larger providers that have more of the infrastructure, more of the resources available to be part of strike teams, to help evacuate facilities, or even FEMA, who contracts with America's largest ambulance service, which is AMR, now called GMR, Global Medical Response. And so the light that's really been shined is that, generally speaking, FEMA reimbursement post-COVID-19 is only available to governmental ambulance services. So my ambulance service, a not-for-profit, 5 ambulances over 1,000 square miles, will likely not be able to receive any reimbursement from FEMA post-COVID-19. We're down significantly, as Steve's numbers showed. We're seeing about a 30 to 50% drop in our call volume. Out of our $20 million a year budget, we do about 10,000 ambulance calls a year. We're going to see probably $1 million loss this year. That will exceed all of our financial reserves. And so others may be able to be reimbursed based on a different kind of ownership type. There's a marked disconnection between what modern EMS is and what it provides. And so where that really shows up is in a number of different places. So TIP, you may hear that talked about a lot, treat in place. Ambulance services all across America have been doing this forever. So they will see a patient, think of a diabetic patient who took their insulin but forgot to eat. So the ambulance service is called when they begin to have a decreased level of consciousness or have lost consciousness, the quote-unquote insulin shock. Ambulance arrives, whether they're BLS or ALS, often administers if the patient can tolerate oral glucose. If they're ALS, they may start an IV and give D50, higher concentration of sugar intravenously. The patient awakes, They ensure the patient is medically stable. They check comorbidities and mortalities, make sure that the setting that the patient is in is stable, have the patient eat something that is a more longer lasting sugar, such as orange juice or a peanut butter and jelly sandwich, and then sign the patient. Well, this really has become pronounced with COVID-19. As ambulance services, we're seeing patients who were showing signs and symptoms of COVID-19, but yet were medically stable. The right thing to do was not to transport those patients and use additional PPE, burden the healthcare system, have them burn additional PPE. If you're in a state like Andes, you may bring them to a small rural critical access hospital who then subsequently transfers them on. Now we have 2 ambulance services and 2 hospitals involved, and you can imagine the cascading effect. Today, that's not reimbursable by CMS. Actually had a call this morning with staff from House Ways and Means to have this conversation. And it was really marked to see the disconnection from what EMS does in the field every single day to what it's believed at the federal level to do, which is primarily transportation. FEMA itself does not list ambulance services in the national response document. You will see them list fire services as all hazard, law enforcement as all hazard. Ambulances aren't listed. All you will see is medical transportation. And so really being able to bridge that gap in COVID-19 has really just, again, shown that light. Workforce, we thought we were challenged with finding and keeping more of the right people prior to COVID-19. Imagine what that's going to look like moving forward. Ambulance services in all of your states have struggled to find even the bare minimum of the PPE they need, whether that was poor planning ahead of time, whether that was a large burn rate, whether that was all of those factors. So personnel, the value proposition, here's what I want from you in exchange for here's what I will give to you, is saying, here, come risk yourself, run towards danger without the right PPE, without meeting the gold standard, still set by CDC of an N95 type mask. Instead, use a surgical mask, use homemade things, and respond on these calls. And certainly for many of you in rural, remote, and austere areas, you certainly have likely seen volunteers unable to respond on ambulance calls because their primary employers are not allowing them to do so for fear of bringing COVID into the workplace. So the national EMS system composition, preaching to the choir here with all the offices and the flex programs. 80% of our ambulance services in the nation are small rural volunteer, often doing 650 less calls, but yet they only respond to about 20%, but yet they cover 80% of our nation. So that disconnection federally, when we think we do something that will cover all, it often is covering governmentals or it's only covering large urban metropolitan areas. And then the devastating effect of the current reimbursement model. Today, the model is simply transportation. The worst thing we could do, quote unquote, during COVID-19 is to transport medically stable patients into the system. Yet, that's the only way ambulances can be reimbursed, at least through Medicare. And they're seeing increased cost in finding and securing PPE. Many of them are unable to get it through the governmental channels, such as emergency management, the strategic national stockpile. They're buying it on the open market. They're buying it through Amazon and other places, often finding things that are fraudulent. And their primary source, the single greatest payer for any ambulance service, is CMS, Centers for Medicaid Services. So lastly, just to suggest a few things that the offices could do. We'll continue to work on these main 4 points you see on the slide, but what are the things that I might humbly suggest the offices could do? Information sharing. There's so much wrong information out there. If you could be that conduit to make sure they're getting the right information from those single sources of truth, such as CDC's, offices of rural health, and others, and offices of EMS. Help with education. So much of this new work that's being asked of them is not something they usually will do. If you ever took a chance to look at one of the PPP, the Payroll Protection Program loan applications. It required a high level of financial expertise to fill one of those out. How would that volunteer running that ambulance service have done it? Help connect the dots for them, connect them into their Office of EMS, their local healthcare systems, emergency management, the long-term care facility, all of those other connections that might be out there. And as Andy mentioned, invest in leadership. Now more than ever, it requires someone who knows how to run a business that just happens to do ambulance transports to be able to not only survive COVID-19, but end up in the other side in a place that they will be survivable, sustainable, and reliable. Thanks.
Thanks, Aaron. So yes, adding to that list of what Flex can do, my overarching statement would be reach out to your Office of EMS and ask them if there is anything the Flex program can do to be involved. I feel like very often I have said, cohort the ambulance services or do this and that, but the first step should be to reach out to the Office of EMS in your state or whoever the EMS folks are in your state, and talk to them about it, see what would be useful and find out what they're already doing and how that involves your rural ambulance agencies and hospitals. Okay, we are out of time. We're a couple minutes over. I am going to go ahead and just announce some upcoming dates. Kiona is going to put up our exit polls, which, like she mentioned, are the same questions but from before. We just want to gauge how you feel you've gained knowledge from this event. So she's got that up. I will tell you that on July 20th, we have our next Task 90, which is going to be Flex program updates and some information about the changing and equip quarterly reports. That is at 2 p.m. Central Time. You should have emails in your inbox about that, including a calendar appointment. Same for the July 27th Flex Virtual Knowledge Group. The topic for that is health equity. And actually, we're very interested in hearing from state Flex programs that are doing work in this area. So if you have some work that you're doing to address health equity, we'd love to hear about it. So send us an email, task@ruralcenter.org, TASC@ruralcenter.org. That event, July 27th, also 2 p.m. Central Time. And then lastly, August 4th through the 6th is the 2020 Flex Program Reverse Site Visit, which is virtual this year. More information to come about that very shortly. And I think that's it. I didn't see any questions in the chat box, so I'm going to guess that there are none. Thank you everybody for attending this webinar. I hope there was something in it for everybody, and that's it. We'll leave that polling question up here for another minute. And then once you've answered it, we'll tell you thanks and have a good day.
Thank you, Nicole. We have 15 more seconds on this polling question, and then I have one final question for our attendees. Thank you to the participants for your feedback today. At the beginning and at the end of our presentation, thank you for all three of our presenters and guest speakers today with the information that you shared. We found it very valuable. As a reminder, the recording will be sent out within 5 business days. You can look for a link with that in your inbox. That's all that we have for you today. Thank you for joining us, and we'll connect soon.
Thanks, everybody. Have a good day.